Structurally, the elbow is a hinge-type synovial joint governing the flexion and extension of the upper limb along a tightly restricted mechanical axis. But this specific, repetitive motion creates an inherent physical bottleneck. Every time the joint bends, the space within the anterior elbow crease violently compresses. This compression threatens to pinch and occlude the primary neurovascular highways traveling into the distal limb. If the cardiovascular system relied on a single straight pipe to deliver blood, normal human movement, like lifting a box or bringing food to your mouth, would cause immediate, severe tissue ischemia in the forearm. Anatomy solves this bottleneck through a specific arterial bypass system. As defined in this clinical text, the anastomosis around the elbow joint is a rich arterial network formed by branches of the brachial artery communicating with forearm arteries. It is built expressly to maintain continuous blood supply during flexion and extension. To understand how the lower arm survives this constant mechanical stress, we have to look past the bone structure. The elbow operates as a highly engineered intersection for fluid dynamics. The geography of this bypass system is anchored by two prominent bony landmarks on the distal humerus, the medial and lateral epicondyles. We can map this space by projecting a three-dimensional coordinate grid over these bony landmarks. This divides the joint into four distinct functional zones: the anterior, or front, and posterior, or back, spaces for both the medial and lateral epicondyles. Through the center of this grid runs the main descending highway, the brachial artery, which bifurcates right at the joint into the radial and ulnar arteries of the forearm. To construct the bypasses around this central line, anatomy uses a strict categorical nomenclature, clearly laid out in the source texts. Collateral branches always descend from the upper arm. Recurrent branches always ascend backwards from the forearm. This establishes the overarching rule for the entire vascular network. The anastomosis is built by mathematically pairing exactly one descending collateral artery with exactly one ascending recurrent artery within each of the four spatial quadrants. We will build this network one quadrant at a time, starting on the medial epicondyle, specifically in the anterior space facing the front of the arm. The first descending bypass branch directly off the brachial artery. This is the inferior ulnar collateral artery, routing downward in front of the medial bone. From below, a corresponding vessel originating from the ulnar artery ascends to meet it, the anterior ulnar recurrent artery. We can confirm this precise pairing in the anatomical reference data. Section 1 explicitly connects the inferior ulnar collateral to the anterior ulnar recurrent in the space directly in front of the medial epicondyle. Because of this completed loop, if the anterior crease of the elbow is compressed shut during extreme flexion, blood simply routes around the medial bone structure to safely reach the ulnar artery. That solves the front, but we also require redundancy for the back of the joint, protecting blood flow when the elbow is in full extension and posterior tissues are compressed. Higher up on the brachial line, another vessel splits off. The superior ulnar collateral artery descends and wraps cleanly behind the medial epicondyle. It is met by its ascending counterpart from the forearm, the posterior ulnar recurrent artery. Again, the source documentation validates this structural pairing, listing these two exact vessels under the heading for the space behind the medial epicondyle. The medial epicondyle is now completely bypassed. A dual-lane biological highway protects the ulnar blood supply, regardless of how the joint is positioned. Transitioning across the joint to the lateral epicondyle requires tapping into a different source. The lateral collaterals primarily originate from a major offshoot called the profunda brachii artery. Looking at this schematic blueprint, we can trace the profunda brachii as it separates from the main brachial artery, specifically to supply the lateral, or outer, aspect of the arm. Following the anterior branch of this deep system, the radial collateral artery descends directly into the front quadrant of the lateral epicondyle. It links with the ascending bypass growing from the radial system below, the radial recurrent artery. This third loop ensures that the radial arterial supply remains pressurized during highly dynamic load-bearing flexion activities, like curling a heavy weight. That leaves only one hidden quadrant remaining to complete the grid, the space behind the lateral epicondyle. The final descending vessel is the middle collateral artery. The schematic clarifies its anatomical path by providing its alternative clinical designation, the posterior descending branch. This posterior branch drops down to intercept the final ascending vessel, the interosseous recurrent artery, which rises from the deep structural tissues of the forearm. The text confirms this last connection point, completing the circuit behind the lateral bone. Zooming out reveals the complete architecture. 8 distinct vessels interlock into a mathematically precise 4-quadrant web of redundant perfusion, entirely encapsulating the elbow joint. Under normal conditions, this network easily handles the kinematic demands of a moving joint. But the true value of the anastomosis is revealed during severe trauma, noted in the applied anatomy text as a ligation or injury of the main brachial artery. If a catastrophic blockage halts downward flow, an intense hemodynamic shift forces blood laterally into the 4 descending collateral arteries. This is the fail-safe. Blood routes backwards up the recurrent arteries, completely bypassing the blockage to backfill the radial and ulnar arteries. The source documentation highlights this exact dynamic as the primary clinical purpose of the anastomosis, providing the necessary collateral circulation to keep the limb alive during an arterial emergency. The vascular grid surrounding the elbow is a brilliant execution of biological engineering. Anatomy constructed a spatial network capable of maintaining steady fluid dynamics through extreme mechanical movement, yielding an impenetrable failsafe against catastrophic arterial failure.